If you recall from part one of this two-part podcast on ischemic stroke update with Katie Lynn and Walter Himmel, Miss Bieber is a 25-year-old female who presented at 3.5 hours after symptom onset with an abrupt onset of facial droop and arm paresthesias. Her presentation was a perfect example of a non-disabling stroke. And that's the topic of discussion for this part two, non-disabling strokes, what they are, important mimics not to miss, how they need to be worked up, how to interpret imaging results, what medications they need, which ones are safe to go home, and which ones need to be admitted. So welcome back, Katie, and welcome back, Walter.
Great to be here, Anton.
Thank you for having me.
Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. First, Katie, can you remind us what a non-disabling stroke is as opposed to a disabling stroke and why this distinction is so important?
Absolutely. So in part one, we talked about disabling strokes. These are strokes that fundamentally affect the ability of the individual patient from living independent life or being able to continue their work or their profession, for example, especially if it impacts ADLs and IADL function. So for example, this would include motor symptoms, particularly of the dominant hand or the legs affecting the ability to walk. It would include speech, severe dysarthria, or severe aphasia would potentially be considered disabling. Vision, especially complete vision loss in one eye, or potentially a complete hemifield visual loss as well. And then altered level of consciousness, which you can sometimes see with some of our brainstem strokes. These would generally be considered disabling strokes. But we also have to take into account the patient's individual context as well. So for example, a mild hand weakness or clumsiness in a patient who is a pianist or a surgeon would potentially be considered a disabling stroke, even though the NIHSS score is low, and even though in another patient it may not necessarily be disabling for their type of function or career. A non-disabling stroke, on the other hand, is one that would still allow that patient, despite the symptoms, to continue living fairly independently with an acceptable quality of life. So this is going to primarily be things like mild facial droop, perhaps a small visual field deficit that doesn't affect daily function. This might include some mild dysarthria, could include some mild weakness that doesn't impact the ability of the person to perform their ADLs or IADLs. And a lot of the sensory symptoms that we see, especially if they're isolated sensory symptoms, these may be non-disabling strokes.
All right, perfect. So that's a little review of what a non-disabling stroke is. Let's talk about age and stroke. So Miss Bieber is 25 years old. We know that strokes are missed in young people partly because they're less common in young people. And we know to think about the most common cause of stroke in young people, and that is cervical artery dissection. So that's carotid or vertebral artery dissection, which we covered in detail in episode 161 with Roy Baskind and Amit Shah. Walter, can you just remind us of why and when we should be looking out for strokes in young people and maybe a little bit about the different etiologies of stroke, because these etiologies of stroke will be very important when we talk about management of non-disabling stroke a bit later in the podcast.
So if you look at many databases like the Center for Disease Control, American Heart Association, European associations, approximately 15% of strokes occur in people under 50 years of age, and a significant number in patients under 40 years of age. Why should we be aware of this? Because strokes happen. And it's a significant misbelief to believe that strokes are all caused by atherosclerosis, and no one under 40 years of age has atherosclerosis. So what's happened recently? Well, first of all, atherosclerosis is increasingly common in patients in 20s and 30s and 40s. We've all seen patients with myocardial infarctions in that age group. So right off the bat, these people can get strokes. And of course, there's a large number of diseases, such as the ones you've mentioned: cervical artery dissections, patent foraminal sickle cell disease, genetic diseases that are associated with strokes in young people, as well as congenital abnormalities of the circulation to the brain. So why should we be aware of this? Because they happen. And to misdiagnose a stroke in a person under 40 is a tragedy. I must give you one very simple example. It's so powerful, it has changed my life. I have a young colleague who, in their first month of practice, was working at a peripheral hospital, and a fellow came in who'd been in the shower. He fell to the ground in the shower, fell to the floor, and became aphasic. Brought to the hospital immediately, and his wife said, "My husband's had a stroke." And of course, after being admitted to the hospital with the psychogenic aphasia, after having seen an emergency physician and an internist, it turned out he did have a stroke. This is a tragedy. So one simply has to assume that young people under 30 or 40 years of age can have atherosclerotic strokes, and atherosclerosis is common in people in the 20s and 30s, and strokes due to non-atherosclerotic causes. That's a lot of people. In North America, we have approximately 900,000 strokes per year. That means 90,000 strokes are going to occur in people under 50 years of age and many under 40 years of age. Keep it on your radar screen and think clinically at all times.
Fantastic. There's actually another quite rare cause of stroke that I think our listeners should know about, because the ED management for these strokes are very different. And this is the anaphylaxis-induced stroke. So that's right. That's an allergic reaction that triggers an ischemic stroke. Another quick story to illustrate anaphylaxis-induced stroke. A friend of mine was hiking in the mountains by herself when she got stung by a bee. She broke out in an itchy rash and some facial swelling, and soon thereafter, she noticed her right arm was weak and she could hardly lift it. And luckily, the anaphylaxis was not life-threatening, and she managed to hike down the mountain and get to an ED. And the astute emergency physician recognized it as anaphylaxis-induced ischemic stroke. And she actually got epinephrine, and her stroke symptoms went away. She actually did okay in the end. Maybe you've heard of something called Kounis syndrome, Kounis. That's anaphylaxis-induced MI, and anaphylaxis-induced stroke has a similar mechanism to Kounis syndrome. So there's a histamine-mediated vasospasm of a neck or cerebral vessel that leads to ischemia in the brain. And just like Kounis syndrome, the big pitfall is withholding epinephrine in fear of worsening ischemia. So that's kind of just a cool, quite rare, but not rare enough that a friend of mine actually had this kind of stroke. And it's just another example of strokes that can happen that are not atherosclerotic, that can happen in young people. Again, PFOs, atrial fibrillation, sickle cell disease, quite a long list, which we'll have in the show notes, but those are some of the more common ones that cause stroke in young people. And so thinking about the different causes of stroke, we also need to think about stroke mimics. And Walter, you had mentioned that about 10% of strokes happen in people under the age of 40. That 10% is also our miss rate of strokes. Emergency physicians' miss rate is about 1 in 10. We miss this all the time. And on the flip side, there's these stroke mimics that we don't identify early as well. So Katie, first, can you tell us what the common stroke mimics are that we need to know about and how they can be distinguished from stroke? And then we can talk about how we suggest we minimize our miss rate.
This is part of what makes emergency medicine so very challenging. The most common stroke mimics include peripheral vestibular disease, perhaps unsurprising to all of us, that dreaded vertigo presentation. It also includes systemic toxic and metabolic causes like hypo or hyperglycemia, which can really mimic any focal neuro symptom. So it's so important to get that glucose early. Encephalopathy and confusion can mimic aphasia and can be really difficult to assess that patient, and electrolyte disturbances like hyponatremia. Additionally, we see focal seizures, atypical migraines, and functional neurologic disorders. In general, I think the most difficult mimics to sort through seem to involve one, vertigo and posterior circulation overlap syndromes for obvious reasons. This kind of needs its own dedicated discussion to delve into the nuances and approaches, so stay tuned for future EM Cases episodes for a deeper dive. Two, confusion. So when patients are confused and difficult to assess, getting that accurate history and physical exam can be quite challenging. And finally, three, patients that lack traditional vascular risk factors. So we've already touched on typically the younger patients. Also, we see from the literature female patients where focal seizures, atypical migraines, functional neurodisorder mimics are more prominent on the differential diagnosis. But we also know from the literature that these subgroups are also at a higher risk for having missed stroke diagnoses. So some general tips for sorting out stroke mimics. Stroke symptoms tend to be loss of function symptoms or negative symptoms. So positive symptoms like seeing flashing lights or scintillations, smelling, tasting, or hearing something, or feeling increased pain or sensation in a limb, things like facial twitching or extremity movements tend to point more towards a mimic, like an atypical migraine with aura or focal seizure, for example. Stroke symptoms tend to come on suddenly and generally all at once. That's not always the case. So, for example, you can have a clot that continues to embolize or a hemodynamically dependent lesion, which can evolve over time. But if you have symptoms that march, spread, or migrate, they, for example, start in the face, then migrate to the leg, this would point more towards a mimic condition as well. Highly isolated symptoms are less likely, though not impossible, to be stroke mimics. So lean heavily on your systematic screening neuroexam for reassurance. For example, isolated facial droop without any other accompanying symptoms. Look for the Bell's palsy lower motor neuron pattern with forehead weakness and inability to fully close the eye. Not a clear lower motor neuron pattern of facial weakness, which can sometimes occur when patients present really early within the first 24 hours of symptom onset. Ask about those bulbar symptoms and look for the associated dangerous Ds to ensure that you've completed and documented your screening neuroexam. This also applies to isolated sensory disturbances. If they're confined to a small region, like the hand or the arm or the foot or the lower leg, they're less likely to be due to stroke. But if larger patterns start to emerge, such as unilateral full-body hemibody numbness, that would be more concerning for stroke, since it would be tough to localize to multiple unilateral peripheral nerves with simultaneous sudden onset. Just keep in mind that glucose derangements can present with any manner of focal neurodeficit, so always check that glucose early on. Also observe for unilateral asymmetries and focal deficits. Many systemic conditions that can mimic stroke tend to affect the body symmetrically, so pay attention to observed asymmetries as a red flag. And finally, don't forget to check for ataxia and walk test the patient. We tend to see our patients in stretchers, and it's important to remember to check for leg strength and both limb and truncal ataxia. This is part of your complete screening neuroexam. Many of the posterior circulation strokes that I've seen missed are due to inadequate cranial nerve screening and not checking for limb ataxia, truncal ataxia, not walk testing that patient.
Those are some great tips and a great overview of the stroke mimics that are common and how to distinguish them. It's almost a whole podcast onto itself, how to distinguish stroke mimics from real strokes. But it can be a tough one. And, often we need to make the decision, okay, does this patient need to be thrombolyzed right now or not? And that can be a very tough decision to try and sort out whether they're actually a true stroke. And you don't want to screw that up because you don't have much time. You really want to, time his brain. Walter, any tips or tricks or suggestions from your experience or from the literature or from anything to help distinguish a true stroke from a stroke mimic so that we don't go wrong in both directions, that we overcall it as a stroke and thrombolize someone who wasn't a stroke, or the other way where we miss the diagnosis, which is, again, quite common.
Sure. Well, I'll make a few comments. And of course, in all things in life, opposites are often true. Point number one, a stroke is a stroke from God. That's why it's called a stroke. Strokes come on quickly. Certainly, they often reach their peak within about 10 to 20 to 30 to 40 seconds. There's exceptions to every rule. Number two, isolated sensory findings or motor findings in the face alone, or an arm alone, or a leg alone are less likely to be strokes, but they can be. But if you have two parts of those anatomy, face and arm, or arm and leg, a stroke is more likely. Number three, do pronator drift testing in everybody. Check the reflexes in everybody, preferably with a reflex hammer. That's tough to find sometimes. Do Babinski's in everybody. Become an expert at looking at those toes. Sit up everybody and make sure they can sit, and then stand everybody. I have many examples of patients who were discharged home, and as they stood up to walk home, they collapsed to the floor. So Katie's absolutely right. The other thing I will say is the following. It is possible, but not common, but possible to have isolated weakness of a hand or isolated weakness of a leg and it be a stroke, but it will come on suddenly. Now, there's many, many differential diagnoses of strokes and stroke mimics. Hypoglycemia can cause focal neurological findings, and I will tell you why. Because all of us are asymmetric. All of us have had insults to our brain starting at birth, and they are exposed by hypoglycemia. This is why hypoglycemia can bring on isolated findings. And the last thing I would suggest is do rapid alternating movements in everybody of the hand and the foot tapping and perhaps the hand. That is a very subtle finding of neurological dysfunction. Now, in terms of the differential diagnosis, the American Heart Association and many journals will list many, but there's three major stroke mimics without fail. Number one, migraines. The symptoms come on gradually. Number two, seizures, often in aura, and the symptoms come on over 20, 30, 40, 50 seconds. And remember, the post-ictal phase of a seizure can last up to 24 hours. And number three, functional neurological disorder is a common cause of stroke mimics in people under 40. Those are the three big ones. The rest are pretty obvious. The last thing I can't resist saying is the following. Contrary to what many of us have been taught, it is possible but rare that isolated, continuous vertigo with gait instability and no other features of the Ds can still be a stroke. And I'll leave it at that for now.
All right, I want to talk a little bit more about functional stroke and how you distinguish a functional stroke from a real stroke, because that's an example where you really don't want to be thrombolizing someone with a functional stroke. I understand that sometimes it's literally impossible to distinguish a functional stroke from a real stroke. Or I know that's true for seizure as well, what they used to call pseudo seizures, but now they use psychogenic non-epileptic seizures that sometimes we can't clinically distinguish a real seizure from not a real seizure, and those patients need to be worked up for a seizure. But in stroke, it's a bit different because we have these potentially dangerous medications that we could be giving them if they present with a disabling stroke picture in under 4.5 hours. So any points or tips in terms of distinguishing a functional stroke from a true stroke, Katie?
A couple of tips and tricks for distinguishing functional neurologic disorders and functional stroke-like presentations. One is distractibility. So are those symptoms persistent, whether or not a healthcare provider is actually actively assessing the patient? Sometimes with our functional patients, you'll see those symptoms come out more when they're actively being assessed. But if you can distract them with something else, those symptoms then go away. there's that inconsistency piece to it as well. So sometimes it's an inconsistency in the pattern of distribution. So for example, if it's, one side of a patient's face, the opposite side of a patient's leg, but then those symptoms switch pattern when you reassess the patient after a couple of minutes, that migratory pattern, that inconsistency is less in keeping as well. From a motor standpoint, there are a couple of tests that you can do to look at. Walter mentioned earlier that pronator drift. So what I like to do with patients for upper extremities, I'll ask them to hold their hands in front of them out straight, like they're holding a tray, palms facing the ceiling. And then I ask them to close their eyes. What I'm watching for as their arm drifts down is a specific pattern of weakness called pronator drift. When it's an upper motor neuron pattern of weakness, because of the asymmetries between your pronators and your supinators, a central pattern of weakness causes a pronation of the weak arm as it drifts down. Whereas with functional disorders, or sometimes if the weakness is coming from a peripheral kind of muscle group or pain, you'll see that arm drift down, but it remains supinated. You don't see that accompanying pronation. That's not as in keeping with an upper motor neuron pattern. The other test that you can do at the bedside is called giveaway weakness. So essentially asking the patient to resist you, and then at random intervals, take that resistance away. If they're truly exerting effort to resist you and activating those muscle groups, you should see their arm continue to move upward as soon as you take that resistance away. If the arm stays exactly where it is, despite the fact that you've taken that resistance away, that suggests that they're not actually exerting that effort. There's a very similar kind of pattern that you can look for called Hoover's sign in the lower extremities as well, which is a little bit more difficult to describe, but is worthwhile having a look through some videos online. There's lots of resources for that too. And then from a sensory standpoint, one of the tricks that I like to use is, again, to look for the distribution of the sensory deficit. I'll often do this a couple of times over the course of my assessment. So I'll do it at the very beginning, and then I'll chat with the patient a little bit, and then I'll come back a few minutes later and retest that distribution. And if that distribution is changed, it is not consistent, that's less suggestive to me of a central true organic cause as well.
Those are some fantastic practical tips that you can do at the bedside to figure out whether a patient has a functional stroke-like presentation or they actually have a stroke. Again, this is one of the top 3 mimics of stroke and are more prevalent in young patients. Walter, any last tips about distinguishing stroke from any of the stroke mimics?
Yeah, I just would love to make a comment about the pronator drift testing. And I've seen this in practice. Pronator drift abnormalities occur in a very stereotypical manner. First, you get the 5th finger sign. When you put your hand into full supination, both arms up, in a positive pronator drift testing, the first thing that happens is the 5th finger starts to abduct from the other fingers. I've read about it. I've seen it in textbooks of neurology, and it is true. Then the hand starts to go into bit of pronation. Then it starts to descend. That is the pattern. 5th finger, bit of pronation starts to descend. That's a lovely test. And of course, sometimes you can't be sure, and you have to have a discussion with the patient, have joint decision making. Now, I've had a couple of shocking moments where someone presented with right hemiparesis. I just had this feeling that this person was having a functional disorder. I said, I think you've had a stroke, and we should consider giving you a clot buster. But I've got to tell you something. There's a risk of bleeding in your brain. On several occasions, it's so dramatic, I've never forgotten it. The patient sits up right away, and it's perfectly fine. So sometimes joint decision-making is your last hope, and sometimes you can't be sure. And there's much literature discussing what happens to patients who have a stroke mimic and get thrombolytics. And it's pretty optimistic, actually.
Yeah, tell us more, Walter. So what happens when a stroke mimic patient gets a thrombolytic? What are the actual risks there?
The reports of bleeding are quite low. They have varied in some small studies from 0 to some big studies to maybe 1% or 1.5%. The risk of bleeding is very, very low.
So is it fair enough to say then that we should err on the side of the patient who presents with an abrupt onset of stroke-like symptoms, assume that is a stroke until proven otherwise, either by a very detailed neurologic exam or a consultation or however else you might do it, that it's better to err on the side that it is a stroke rather than a stroke mimic when you're kind of waffling and on the border. Is that fair enough to say?
With a few caveats. You must have a discussion with the patient and or family, have a role of joint decision-making. It has to be an informed decision. And of course, we're talking about disabling strokes, not non-disabling strokes or TIA.
Yeah, fair enough. Katie, any comments about erring on the side of, yes, this is a stroke when you're not 100% sure?
I completely agree with Walter. The safest assumption to make when you have a patient with sudden onset disabling symptoms is that this is a stroke until proven otherwise, regardless of whether they have a history of migraines, atypical or otherwise, whether or not they are a young patient with lack of vascular risk factors. We know these patients are at higher risk for being missed. And so if you're uncertain, if you're on the fence, assume a stroke until proven otherwise. Use the tips and tricks that you have at the bedside to help guide your clinical judgment, and be very cautious of being the first person to make a functional neurodiagnosis in a patient with acute onset disabling symptoms. The risk of hemorrhage after thrombolysis, as Walter has mentioned, is significantly lower in patients who have stroke mimics, which makes sense physiologically because they don't have that ischemic insulted brain, which is at higher risk of hemorrhage. So as Walter had said, generally pooled risks for symptomatic intracranial hemorrhages hovers around 0.5% in the mimic group if you look across studies, but anywhere from 0 to 1% is usually what you see in the literature.
Okay, fantastic. And for non-disabling strokes, which we're talking about most of this podcast, we have a little bit more time. We're not going to be thrombolizing those patients. Those patients don't need to go for emergency EVT. So we have a little bit more time with those patients, and then we can spend some time doing a detailed neurologic exam and get a consultation and then make a final decision.
One final note that I'll add as well is if you look at the literature, amongst patients who have functional neurologic disorders, about 60% of them actually have an organic underlying medical condition, whether that's a psychogenic seizure patient who actually has an underlying true seizure disorder, or a functional neurologic disorder that presents as an acute stroke-like presentation. Those patients may have a risk of actually underlying stroke conditions. Sometimes it's due to a component of sort of psychogenic anxiety and extra surveillance around even minor symptoms. And sometimes patients try and help us, whether consciously or subconsciously. And so they exaggerate their symptoms, and they can present as if they are functional in terms of their weakness pattern, but they're actually just exaggerating some real symptoms that they're experiencing because they're trying to help us detect it on their exam. So just be very cautious.
Wow, that makes it a bit more complicated. So again, the bottom line is assume that it's a real stroke until proven otherwise.
A quick word from one of our sponsors, Rural Ultrasound Fellowship. Hey POCUS fans, ever consider an ultrasound fellowship? In just 1 year, go from solid POCUS user to full-on expert. No career pause and no travel required. The RUF's world-class faculty has trained over 40 ER docs and rural GPs from around the globe. Fully online, fully flexible. With a 97% completion rate, it really works. Re-energize your practice. Boost your confidence. Visit ruralultrasound.com to learn more. That's RURAL ultrasound.com.
Any last comments about the miss rate and how to minimize that miss rate of strokes?
When it comes to TIAs and non-disabling strokes, it's really about trying to reduce the risk of a subsequent stroke. So we know that the risk of subsequent stroke is significantly higher within the first 7 days of an initial event, whether it's a minor event, a TIA event, a non-disabling stroke event. That patient is at higher risk over the next 7 days, and especially in that next 48 hours. We know that stroke is the 4th most commonly misdiagnosed condition in the emergency department, actually. And if we miss that initial diagnosis in our patients, short-term morbidity and mortality are 8-fold higher for those misdiagnosed patients. So patients with their non-disabling stroke or TIA symptoms are at a risk of anywhere from 2 to 17% of having a subsequent stroke event within the next 90 days. And most of that risk, again, is front-loaded in the first 48 hours. Now, this time, they had a TIA or a non-disabling stroke. They got lucky. But next time, they may not be so lucky and they may be left with a significant disabling deficit. There are patient factors and presentation factors that contribute to missing those stroke diagnoses and TIA diagnoses. And we've already touched on a lot of them so far, right? So on the patient side, if patients are female, younger in age, if there's racial or ethnic minorities and language barriers involved, that can also increase the risk of missing that diagnosis. And then there's also those presentation factors that make it much more challenging to pick up. So if those symptoms are transient or minor, you're relying on the patient's description, which can sometimes be more difficult to suss out. Non-lateralizing symptoms, and that's often what makes it so difficult with those posterior circulation strokes, and altered mental status, where it's a lot more difficult to get an accurate sense of what happened and what that patient's exam is.
Okay, let's move on to risk stratification. So we have Miss Bieber, who has a non-disabling stroke. And the first thing we need to sort out for non-disabling strokes, as per our algorithm that you can follow along in the show notes, is whether or not they have persistent deficits or high-risk features. Katie, could you first explain to us why it's important to sort out the persistent deficit and high-risk features so that we can risk stratify these patients with non-disabling strokes or with TIAs for that matter?
Remember that TIA and minor stroke are part of the same stroke continuum. The DOUBT study from 2019 showed that 13% of TIAs with symptoms that resolve within as little as 5 minutes actually end up having stroke lesions on MRI and end up being reclassified as minor stroke. The reason we now treat high-risk TIAs and minor non-disabling strokes essentially the same is because they are predictive of a subsequent disabling stroke event, again, in up to 20% of patients within the next 90 days. And it is the subsequent disabling stroke that we really want to prevent.
So non-disabling strokes and TIA are part of the same spectrum. And as you'll find out soon, they're treated pretty much identically. And at a later date, we will do an entire episode update on TIAs, but I think we need to talk a little bit about TIAs here because there's so much overlap with non-disabling strokes in how we manage them. And to start with, I just want to talk about the high-risk features when it comes to TIA. We have the Canadian TIA score. We have the ABCD2 score, which we used about a decade ago to help risk stratify patients who presented with TIA-like symptoms. Should we still be using the Canadian TIA score or the ABCD2 score to help us sort out high-risk features for patients who present with TIA-like symptoms?
So if you look at the Canadian Stroke Best Practice Recommendations Guidelines, the ABCD2 score has been taken out from the last couple of editions, partly because in a practical, real-world setting, it didn't perform as well as it did during its validation and derivation studies. It's really useful, I think, in an academic sense for helping us look at patients and compare them apples to oranges. Not so useful, I think, for us as frontline clinicians. In terms of the Canadian TIA risk score, I think that there's some promise there, and it's an additional tool that you can keep in your tool belt. I have not seen it widely utilized yet, and perhaps part of that is due to the fact that you require likely a calculator to remind you of all the different components. In actuality, I think it's really most important to come back to those first principles of what are the disabling symptoms that we care about, right? Speech, motor, vision, altered mental status. Those are our disabling symptoms. And when it comes to TIAs, symptoms that have resolved, we're looking for those same disabling symptoms to help us define those high-risk TIAs. The reason we care about those high-risk TIAs is A, because they are increased likelihood of being an actual ischemic event as compared to a potential mimic, what we talked about before. And B, because if this was a TIA event or an ischemic event that transiently happened and is now resolved, We care about those disabling symptoms because that suggests that something in that patient's vascular anatomy puts them at risk for having a disabling stroke affecting that same blood vessel, whether it's because they have a stenosis in that area, a dissection in that area, an occlusion that's hovering in that area and embolizing, or their anatomy just makes it easier for embolic pieces of clot to travel up into that vessel. Something about that patient's brain puts that part of the brain at risk, and those parts of the brain are the most important functional parts that could result in a subsequent disabling stroke.
There are many viewpoints. Let's step back and look at history. Why does risk stratification ever be looked at in the first place? It's because 25 years ago, if you had a TA or a minor stroke, nobody did anything. It's because resources in many countries are limited. It's because stroke management and early investigations were not available. So you had to come up with risk stratification tools to determine who would be managed aggressively and who would not. So there's something called consequential knowledge. What knowledge really matters and what knowledge matters less. Now you've got the Ottawa group and you've got the Calgary group. I go with the Calgary group. And here's what the Calgary group says. There's two important features in stroke that makes it high risk no matter what. It's not your age. It's not your blood pressure. It's not the presence of diabetes. It's not even the presence of atrial fibrillation, although in a large population, those things matter. Now, here are the two most important factors that make a big deal and to me mean they're getting the workup immediately. Number one, was your speech affected? Do you have dysphasia, aphasia, or dysarthria? And number two, do you have motor weakness, paresis? It's not about the A, it's not about the B, it's about the C, the clinical features. If you've got motor weakness, if you've got speech deficit, that is a big deal, and that's high risk. Those are the big two features. As every pirate knows, it's all about the C, the clinical features, motor weakness and speech deficit. That is a big deal. Now, we know you can have a sudden onset of hemisensory abnormalities. That, of course, could be a stroke, a small thalamic stroke. They tend to have a pretty good prognosis. Now, when it comes to posterior circulation disorders, that's a whole different picture. But it's all about the C. If someone had a sudden onset of speech deficit, aphasia, dysphasia, dysarthria, or a sudden episode of weakness. And remember, many people with weakness don't say I'm weak. They say my arm is heavy. Those two things matter a lot.
When it comes to TIA and non-disabling stroke, at its core, it's just about preventing that secondary stroke event from happening at all, right? And especially because that secondary stroke event could be the big disabling one, and we want to be able to prevent it. So it's all about predicting the risk for a subsequent stroke event. Patients with high-risk TIA symptoms, these are speech, motor, and in my mind, vision, and potentially mentation, symptoms that are transient, they've resolved. Those high-risk features are more predictive that this is a stroke as opposed to a mimic, and therefore this patient is at higher risk for a subsequent stroke event. When it comes to persistent, non-disabling minor stroke symptoms, these patients are still at risk for having a subsequent stroke event because we know from prior studies that if you have one stroke, you're at risk for more strokes, and that risk is especially high in the next 48 hours to 7 days. So again, for both TIA and minor stroke patients, really what we care about is preventing that next subsequent stroke event. And we can put in place our secondary prevention. We can look for what's causing their stroke so we can apply targeted therapies. But that's why we care, and that's why we treat both of these populations very similarly.
And that's why both these patient populations need the urgent CT, CTA, and consult so that you can get them sorted out and started on the right medications.
I agree totally. They need a CT primarily to see if there's a significant stroke and to look for stroke mimics, like a tumor or a subdural. They need a CTA for a very simple reason. Do they have a surgically correctable lesion? And they need an ECG or prolonged ECG to see if they have atrial fibrillation. That's your three questions. Is it a structural mimic? Do they have atrial fibrillation? Do they have a surgical lesion? Those are the three big questions that are not clinical. And of course, in speaking to radiologists, here's what you have to know. According to the Canadian guidelines, any TIA in which you're seeing the patient within 48 hours, the Canadian guidelines consider they should be investigated immediately. After 48 hours, it doesn't necessarily have to be immediate. But there's no doubt about it. If I see somebody with some minor sensory findings, it's not that urgent, although it's still important. If I see someone in front of me with a clinical features of speech or motor weakness, that's always a big deal. Always a big deal. Whether it's disabling stroke or non-disabling stroke, they need investigations. A CT to look for mimics and evidence of a stroke, a CTA to look for surgically correctable lesions, an ECG or other tests to look for whether they require anticoagulation or not. Those are the big questions that it would be nice to answer in the emergency department before the patients go home in 2025, depending on the resources in your community. In my community, I got a lot of resources if I know how to negotiate with some radiologists, and I do. And those are the questions I want to answer. If you're in a resource-depleted environment, you may have to modify this.
In terms of the workup for a non-disabling stroke, we don't need a CT-CTA this second like we do in a disabling stroke. So, Katie, could you just talk briefly about the timing of getting the CT-CTA for non-disabling stroke as opposed to disabling stroke?
So for disabling stroke, that's when we're in that situation where every second counts and you want that imaging stat so that you can get that patient to their diagnosis and to their revascularization therapy as soon as possible to save as many neurons as you can. For TIA or non-disabling stroke, you have hours as opposed to seconds and minutes. So you can put that in as an urgent request for imaging, get it on the slate, and depending on where you work, that urgency is going to be a little bit different because of resource availability. But you don't need that CT-CTA stat in a TIA or non-disabling stroke. You do need it in that disabling stroke to be done immediately or as soon as possible. That's the difference.
So stroke, disabling, CT-CTA immediately, non-disabling, CT is often done right away, and the CTA can be deferred. Some people would argue even for a day or two.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
Before we get on to medications for non-disabling stroke, I want to talk about endarterectomy. So there are some high-risk TIA patients who will require an endarterectomy, and there's some patients with non-disabling stroke that will require an endarterectomy. So Walter, could you just review for us what the indications are for endarterectomy for patients with high-risk TIA and for patients with non-disabling stroke?
Of course, thank you. It's a great question. Stenosis of the carotid artery is a clear-cut risk factor for TIAs and a clear-cut risk factor for strokes. If you've got a stenosis of the carotid artery between 70% and 99%, a stenosis of the carotid artery, the ICA, between 70% and 99%, and you've had a TIA, the risk you've got of having a major stroke in the next 2, 3, 4, 5 weeks is as high as 25%. So anybody who's had a TIA or a non-disabling stroke has a carotid artery stenosis of 70% to 99% needs to have an endarterectomy or a stent. In the same clinical group of patients, if you have a carotid artery stenosis of 50% to 70%, the risk of a stroke in the next few months is also quite high, but not as high. And in most centers, these patients also require an endarterectomy. So basically, anybody with a TAA or a minor stroke and a carotid artery stenosis of 50 to 70 or 70 to 99 requires an endarterectomy, along with excellent medical management.
And what about the timing of the endarterectomy?
That's a great question, and I will tell you the answer, okay? Not the first 48 hours after a stroke. In the first 48 hours after a stroke, if you do an endarterectomy, the risks of causing ischemia or bleeding are dramatic. So most surgeons will do an endarterectomy somewhere between 3, 4, 5, 6 days and a week, and certainly within the first 2 weeks, but not the first 2 days. Within the first 2 weeks, but not the first 2 or 3 days, because everything is too hot. It's like fixing your car when it's still boiling hot. You're going to burn your hands. It's not going to go well. The car's got to get its temperature calmed down before you fix the car. No one does endarterectomy in the first 48 hours. After 2 days, within 2 weeks is ideal. Between 2 weeks and 12 weeks, the benefits get less and less and less and less. And by 12 weeks, the benefits are pitifully poor. This is why you want to get the CTA in the first or second day, and you get a call in your surgeon, and they'll go ahead and arrange for the endarterectomy if the stenosis is between 50% and 99%. And by the way, there's also studies looking at carotid artery stenosis in people who've never had a TA, have never had a stroke. That's called an asymptomatic carotid artery stenosis. And we do know if you happen to find that in somebody, and it's more than 60% based in studies, they still benefit from endarterectomy, but a lot less, and it's less urgent.
I completely agree with Walter. I think just to simplify and really boil it down for our listeners, if you have a patient who has TIA or non-disabling stroke-like symptoms, and on their CTA it shows a carotid stenosis of greater than 50%, call a friend, phone a friend, ask for help, and we'll help guide you from the stroke standpoint. Because those patients may benefit from carotid endarterectomy or stenting, and we can help sort out the timing on that.
So we've talked about indications for endarterectomy for non-disabling strokes. We've talked about stroke mimics. I'd like to move on now to medications for non-disabling stroke. So these patients are not candidates for thrombolysis by definition, but there are a few options for other medications for these patients depending on the cause of their ischemic stroke, their bleeding risk, and what medications they're already on. So Walter, what medications are you giving for these non-disabling stroke patients? The medications they require to prevent that big bad stroke will again depend on the etiology of the stroke. You know, is it arterial stenosis in the head or in the neck? Is it a dissection in the neck or the head? Or is it a thromboembolic stroke from AFib? Or is it another cause? And in particular, the AFib one always gets me a bit nervous because those patients I know need a DOAC, but I'm really reluctant to start a DOAC immediately in the emergency department, worrying that it might cause a bleed. And I understand that that's a bit controversial of exactly when to start the DOAC. So let's just start with your run-of-the-mill, presumably atherosclerotic, non-disabling stroke patient. What medications do they need in the emergency department, and what medications do they need going forward?
That's a great question. Of course, it often falls in the hands of the emergency physician to start antiplatelet agents. But before I even discuss that, I want to point out the following. They also have to have their blood pressure managed. They may need ACE inhibitors. They may need statins. And the custom at the present moment is those questions are answered later by a neurologist or a stroke clinic. And the common understanding is, at least at the moment, it's the emerge doctor who should begin the antiplatelet agents. So what are the agents that are commonly used at the present time? Well, they include aspirin, clopidogrel or Plavix, ticagrelor. Those are the ones that should be within the knowledge base of the emerge doctor to begin prescribing in TAAs. non-disabling strokes, and also in strokes in which you are not having a thrombectomy done. They also need antiplatelet agents. Of course, the question is, do you give one agent or do you give two agents? And the research on this has been going on endlessly. So what was the traditional answer? The traditional answer was aspirin. So certainly, if you have a TAA, and here where high risk and low risk really matters actually. If you have a TAA, either high risk or low risk, or if you have a stroke, presumably not due to atrial fibrillation or an embolism, a venous embolism or that's gone into your brain, what's the drug? Well, certainly aspirin is a traditional drug, and it's perfectly reasonable to start aspirin. And you always give a loading dose, which to Canadians is 160 milligrams, and to Americans is 325 milligrams. You preferably give the aspirin you can chew, and you always give a loading dose. Can you use an alternative to aspirin? Yes, you can. You can use clopidogrel alone. And the research in that goes back to the Capri trial, which is probably 30 years old when Katie was back in kindergarten, or perhaps not even born yet. And I remember when those studies came out.
Katie is wise beyond her age.
Absolutely. Absolutely true.
I felt I had to defend you there,
He's
Katie.
getting better, and I'm starting to go downhill. So you could use clopidogrel. And what's the dose of clopidogrel? You give a loading dose of 300 milligrams in the department, and then 75 milligrams a day. You could do that as a single agent. Now, of course, you've got ticagrelor. When might you use ticagrelor? Well, if you don't want to use aspirin, and you have a allergic reaction or sensitivity to clopidogrel, which, by the way, I do. I got thrombocytopenia from clopidogrel. You have another option these days. It's called ticagrelor. And you can give a 180 milligram loading dose in the emergency department, just like you do for coronary artery disease. And then 90 milligrams twice a day after that. Those are your three options for single agents, which are antiplatelet agents. Is there any clear-cut benefit to one of those over the others? Not really. And if there is, it's very, very, very slight and controversial with confidence intervals that cross zero. So any of those three are fine. The next question is, when do you start? Immediately, when you've made your diagnosis and when you're sure there's not a AV malformationist bleeding or a subdural or a subarachnoid. Immediately is when you start those drugs. How about dual antiplatelet agents? This is where the term high risk or low risk TA seems to be important. In all the studies where they've looked at dual agents versus single agents, they've pre-selected patients who have high risk TAs. Those are the studies. Now, of course, this makes perfect sense. If you have a sensory TAA involving your face and your hand, it might not even be a TAA, but it might be. But the studies have used patients where they could show a difference. Pharmaceutical companies are not dumb, and it makes sense from a biological viewpoint. So if you've got a high-risk TA, which means what? Well, you know my viewpoint. It's all about the C. If the C is motor weakness or speech deficit, that's a high risk, in my opinion. You can use the ABCD2 rule. I wouldn't recommend it. It was very important in the past. I would consider it now a lot less relevant. I would never say irrelevant, although I might think it. I would never say it, but a lot less relevant. And the Canadian TA rule is nice. They have low risk, medium, high risk. It's so bloody complicated. I get a migraine just thinking about it. But I do use the C. If the C is present, you would probably use dual antiplatelet agents, with one exception. And what are the agents? You can use aspirin and clopidogrel, aspirin and ticagrelor. Those are your options. There's 5 big studies, the POINT study, the CHANCE trial. There's further studies. This has been studied and studied and studied. And here's what the bottom line is. You can use aspirin and clopidogrel in high-risk TAs, not in strokes yet, but I have to comment on that later. Aspirin with a loading dose of 116 in Canada and 325 in the USA, and clopidogrel. And the loading dose for clopidogrel in the stroke context is 300 milligrams and a 75 a day. Or you can give aspirin and ticagrelor. Aspirin as described and ticagrelor with a loading dose 180 milligrams, and then 90 twice a day. Now, how long do you give dual antiplatelet agents? There's many answers, but the common answer is 21 days. And here's the reason. Biggest risk is the first 21 days. The biggest benefit is the first 21 days. And the risk of bleeding tends to go up after 21 days. So it's 21 days.
So Walter, could you just clarify there? So for a high-risk TIA, you're giving dual antiplatelet therapy, and your options are aspirin load of 160 or 325, then 80 milligrams a day, plus clopidogrel 300 load, and then 75 a day, or ticagrelor 180 load and 90 BID for 21 days.
Absolutely.
So that's for high-risk TIA.
Yes.
What about for non-disabling stroke? Is it exactly the same or is it different?
That is a great question, and I have plagued the funerologists in this question. Now, non-disabling stroke is going to be treated exactly the same as TIA from an antiplatelet agent viewpoint. TIA, non-disabling strokes are treated identically the same way in regards to antiplatelet agents, exactly what you've summarized.
All right. So just to summarize there, high-risk TIAs and non-disabling strokes are given the exact same dual antiplatelet therapy, assuming that there's no major contraindications for presumed atherosclerotic, run-of-the-mill, high-risk TIA or non-disabling stroke.
I would say absolutely yes, 3 times.
Excellent. Now, just to make sure that our listeners are clear, for disabling strokes, which we talked about in the last podcast, my understanding is that they do not get dual antiplatelet therapy. They get single antiplatelet therapy. Is that correct?
That is the standard answer. Correct.
Now there's the patient who, let's say we discover, has atrial fibrillation in the emergency department. They do not take a DOAC, and we suspect that the atrial fibrillation has caused their non-disabling stroke. When can you start those patients safely on a DOAC? When is it recommended? What does the evidence say?
This is an area of evolving research still within the stroke literature, but over the last 5 years, what we've actually learned is that we can probably start our anticoagulation a lot sooner than we previously thought. Historically, the concern with starting a DOAC in patients who have had TIA, minor stroke, is that they may be at slightly higher risk for evolving a hemorrhage if we start them too soon. So traditionally, we had held those anticoagulation medications for 3, 5, 7 days, depending on what we see on the imaging. There have been more recent studies that show that not only is it safe to start those anticoagulants a lot sooner, sometimes even within the same day as their actual event, but also that those patients who receive their DOAC sooner actually tend to do better at 90 days in terms of their actual functional outcome, because they're at less risk for developing a subsequent ischemic stroke, and the overall risk of hemorrhage is lower than we had initially thought. So, as with so many things in medicine, Anton, the answer is going to be, it depends. It depends on what the patient presented with, their symptoms, how long they lasted. Was it a TIA? Was it a minor stroke with persistent non-disabling deficits? And it also depends on what their imaging looks like as well. What is the size of any sort of infarct that we are potentially seeing on imaging? I would say that in the world of TIA, most of those patients, if not all of them, can start on that DOAC immediately within the same day, provided we have imaged them and excluded any sort of intracranial hemorrhage as the source of their symptoms. For patients with persistent non-disabling deficits, most of those patients can likely start their DOAC within the next day or two. And that's going to be a conversation that you can have with your stroke consultant to help guide that decision. And I would certainly say, especially for those non-disabling but persistent symptom patients where you suspect a minor stroke, have a chat with your friendly neighborhood stroke physician to help guide that decision-making.
Great. Call a friend. Love it. So far we've talked about the run-of-the-mill atherosclerotic non-disabling stroke that requires dual antiplatelet therapy, just like a high-risk TIA. We've talked about the patient who you discover has atrial fibrillation and their stroke is presumed to be due to atrial fibrillation. And most of those patients can actually start a DOAC within the first day or two, but you need to call a friend to discuss exactly when they're going to start it. What about the patient then with a neck dissection that's causing their stroke? I always think if the patient's dissected, I'm really reluctant to put them on any kind of blood thinner. And again, you have these choices of single antiplatelet therapy, dual antiplatelet therapy. Do they need an anticoagulant? Do they need low molecular weight heparin? I think all of these things have been studied and tried. Walter, what is the standard treatment in 2025 in terms of medication for an ischemic stroke caused by a neck dissection or an intracranial dissection, which I understand the treatment's a little bit different if it's a neck dissection or an intracranial dissection?
It is. Let's look at neck dissection. In the absence of a TAA, neck dissection in the absence of a stroke. You happen to diagnose a neck dissection, not a TAA, not a stroke. The studies looking at this question, and there aren't that many, have only compared the following options: a single antiplatelet agents versus anticoagulation. I'm talking about dissection, no stroke, no TAA. This is dissection. They've looked at anticoagulation versus antiplatelet agents. And here's what the conflicting studies and meta-analysis tend to say. One of the meta-analysis suggests that giving anticoagulation for a dissection, cervical artery dissection, more or less is as effective as giving single antiplatelet agents alone. One meta-analysis suggested that. By the way, they're treated for about 6 months. Another meta-analysis suggested there may be a slight benefit to giving anticoagulation for dissections initially. There's a controversy about that. But I would say from an emergency viewpoint, if you have somebody and you've diagnosed a dissection based on a neck pain or a motor vehicle accident and a CTA in the absence of a stroke, it is single antiplatelet agents. The treatment of a dissection in the absence of a stroke or TA, they've never studied dual antiplatelet agents in that simple context. So some older neurologists will go with anticoagulation. Most will not. There's exceptions. Most will go with a single antiplatelet agent. Now you've got a dissection with a stroke. So here's what the approach to that is. Are you treating a dissection, or are you treating a stroke or a high-risk TA who happens to be caused by a dissection? In most cases, in my opinion, if someone's had a high-risk TA, it's all about the C, and they have a dissection, I'd probably go with dual antiplatelet agents, because I'm basing it now on the studies of the treatment of high-risk TAs and non-disabling strokes. And you've got the aspirin and Plavix versus, or Clopidogrel, I guess I should be saying, or the aspirin and Caglor, but most will use aspirin and Plavix. And that's the answer to there. The only exception here is if this patient, and I have to step back a bit, is going to be considered for a stent, before you begin dual antiplatelet agents, speak to the surgeon who's going to be doing the operation. Some of them do not like Plavix before surgery. So once again, carotid artery dissection, no stroke, aspirin alone, and in some cases anticoagulation or Plavix alone. Carotid artery dissections with a high-risk TA or a non-disabling stroke, probably dual agents. I'll see what Katie thinks.
I'll give a simple answer here, but first of all, I will start by saying these can get quite complex, and so don't hesitate to call for help. And again, phone a friend for advice. Your stroke specialist can give you some guidance on this as well. There are 3 things that I look for when I'm making this decision as a consultant. The first is whether or not there is a component of intracranial hemorrhage or subarachnoid hemorrhage present, which can be concurrent with either ischemic stroke or sometimes with dissection that extends intracranially. So if there is any sign of bleeding intracranially, whether that's an intracranial hemorrhage or subarachnoid hemorrhage, unfortunately, we have to hold off on all these agents until we get that stabilized, and then we start it at a later date. So that's the first thing. The second thing I care about is where is that dissection happening? Because an arterial dissection can happen at a couple of different levels. We know that you can have an aortic dissection that extends into the carotid. That's a very different beast from an isolated cervical artery dissection of the carotid artery or vertebral artery. And it's also a different situation if we're dealing with an isolated extracranial cervical artery dissection versus an intracranial artery dissection. The reason we care is because the bleed risk is different between those three different scenarios. So in an aortic dissection, I would not be starting any antiplatelet therapies on that patient until we've stabilized that aortic dissection. In an isolated extracranial, carotid, or vertebral dissection, most of those patients are going to be dual antiplatelet therapy. If there is any extension of that dissection intracranially, that's where the risk for subarachnoid hemorrhage starts to go up because that muscular layer of the arterial vessel gets much, much thinner as soon as it extends intracranially. So those patients, we have to be a lot more cautious. And that's where I'm going to use some of my clinical judgment based on the appearance of the dissection, the patient's physiology, the overall appearance of the imaging to make a decision about single antiplatelet therapy versus holding off on any antiplatelet therapy versus possibly considering dual antiplatelet therapy if I think the risk is low enough for hemorrhage but high enough for ischemia. So that's where it's a little bit more of a gray zone, is if there's an intracranial artery dissection extension. And finally, the last piece, that third piece, is whether or not the dissection has actually occluded. So when we dissect, we can then cause a clot to form on that dissection flap. Sometimes that clot can occlude the artery entirely, or the dissection flap itself can occlude the artery entirely as well. When we look at the studies, it's suggestive that those patients with an arterial occlusion from their dissection benefit from anticoagulation. So those are patients I may be starting on anticoagulation with their dissection because their risk for having an ischemic event from that occlusion is so, so high. And their outcomes are better when we put them on anticoagulation. But those are also patients that are going to be much higher risk that are going to need to come into hospital for monitoring.
So not every dissection is the same. Most dissections are going to be in the neck. They're not going to involve the aorta, and most of those will require dual antiplatelet therapy. However, there are a few exceptions, which Katie just outlined for us. And so a call to your friendly neurologist is going to be necessary to make that decision. And now a word from one of our sponsors, Paratus, the all-new emergency assistant. Paratus combines everything you loved about Easy Resus with powerful upgrades, just-in-time procedural guidance, stress-proof organization, and Atoms, the intelligent assistant that helps you find exactly what you need. Whether you're in the ER, on transport, or in the field, Paratus keeps you ready for anything. Learn more and start your free trial today at paratusmedical.com/emcases. That's PARATUS medical.com/emcases. Before we wrap up about the medications that we give in the emergency department for patients with non-disabling stroke, we haven't yet talked about blood pressure management of these patients. So let's assume that your non-disabling stroke patient, that you have one patient that has a blood pressure of 170 over 100, and then you have another patient that has a blood pressure of 200 over 125. How do you manage blood pressure in these patients? I mean, we know that we don't want to drop blood pressure too precipitously because that can cause more ischemia, but we also don't want their blood pressure to be so high that they're going to end up with a bleed. So how do you balance that? And what are the current recommendations in terms of blood pressure medications required for patients with non-disabling stroke? So again, this is going to be different than the disabling stroke who needs to be thrombolized or go for EVT. This is the patient with non-disabling stroke. How do you manage their blood pressure?
So the guidelines would generally say that you actually allow those patients to ride high with their blood pressures in that first 24 to 48 hours. This is permissive hypertension to try and reduce the overall size of the ischemic infarct because these patients are not going for reperfusion. And so I generally will let that systolic blood pressure go up to 220 or that diastolic up to about 110 for the first 24 hours. And then I will gradually lower it, usually with oral agents, not too quickly within sort of that first 24 hours. And in fact, you often see that happening naturally and spontaneously with these stroke patients, these minor stroke patients. They'll be high for the first 24 hours, and then you'll actually see that blood pressure come down on its own, often at that 24-hour mark, before you have to initiate anything. Generally speaking, above that 220/110 point, you're no longer getting that benefit of perfusion, and you're starting to get outside of that range where cerebral autoregulation is working for you. So that's the point at which I might give them something oral to slowly bring them down.
Okay. And Walter, if you are going to give someone an oral medication who's had a non-disabling stroke, who, let's say their blood pressure is 225/220 in the emergency department, what would be your choice of medication?
Two that are commonly used right now orally would include ACE inhibitors, such as ramipril, and calcium antagonists, such as amlodipine. Those are commonly used. And you would start with moderate doses, perhaps 5 milligrams of ramipril or 5 milligrams of amlodipine, and watch them over the next several hours. There's no big rush. And certainly, you would not want to drop the pressure more than about 20%. And the guidelines have been unchanged for decades in patients who are not getting thrombolysis and not getting EVT. Pressures of 200, 210 over 100, 110 are left alone the first 24 hours. They often require that pressure. And I've certainly seen some very enthusiastic doctors exceedingly lower the pressure with some very unpleasant consequences. Once your diastolic, as Katie said, and I agree totally, and this is completely consistent with worldwide guidelines, once your diastolic is 110, 120, you're going to bring it down about 15 or 20% gradually over time. And certainly, people with moderately high blood pressure, 190, 200 over 100 in the first 24 hours, often spontaneously will lower over the next 24 hours.
All right. I think we've talked about everything anyone would ever want to know about medications for non-disabling stroke. I want to move on to disposition. So there's many patients that we assess for TIA at the emergency department that we can send home, and we have very good systems in place to take care of those patients. What about for the patient with non-disabling stroke? So let's say Miss Bieber has her facial droop and arm numbness. These are persistent symptoms. She still has them. Do all patients with non-disabling strokes require admission to hospital? Why or why not? Is it safe to send these patients home after their CT, CTA, after their initial ED workup?
This will depend a little bit on your local systems of care and your access to community follow-up resources. But in general, not all of these patients need to be admitted to hospital for their workup. For example, in Calgary, we have a stroke prevention clinic in the community that's able to see these patients within the span of a couple of days and organize the additional imaging and workup that that patient may require. So a lot of these patients, if they have persistent deficits, will get at my center a CT-CTA, but the subsequent workup can happen as an outpatient in close follow-up with a neurologist.
So Walter, assuming that the patient gets their CT-CTA in the emergency department, any other comments in terms of the safety of sending patients with non-disabling stroke home?
Reliable patient, reliable family, reliable system, they can often go home. Unreliable patient, unreliable family, unreliable system, I would favor keeping him in the hospital.
Fair enough. And Katie, just to get a sense of when these patients do follow up, let's say you have a stroke prevention clinic or something similar that they follow up in 3 or 4 or 5 days after they've had their CT, CTA in the emergency department. What kind of testing do they then do in terms of which patients would be getting an echocardiogram, which patients get an MRI, which patients get a CT perfusion or some other test? What's generally the workup that's happening there?
Most patients are in follow-up going to receive MRI because we want to confirm whether or not there's a lesion there that would suggest that minor stroke event. A lot of those patients are going to receive an echo, especially looking for PFO, but there's also a couple of other structural cardiac things that we look for. Valvulopathies, for example, left atrial appendages that are enlarged, deep trabeculae in the ventricles, which can all increase the risk of a cardioembolic stroke. And then most of those patients will receive Holter monitor testing as well, looking for subclinical atrial fibrillation as a risk factor. So that's the trifecta that we would use to risk stratify most of our patients and investigate most of our patients is MRI, Holter monitor test, and echo with bubble study. Some patients will receive some additional testing as well. And so that might include specific blood work looking for thrombophilia type conditions. That might include some additional investigations, specifically looking at the vessels in more detail. So DSA studies or angiography studies, for example. But for the most part, those are the ones that we rely on.
Perfect. All right. Any last words of wisdom before we head into our summary for non-disabling strokes? Katie?
Any sudden onset neurologic symptom, think about the possibility of stroke regardless of the patient's age, vascular risk factor status, prior history of migraines or seizures. The thought of stroke must cross your mind, and that should prompt you to ensure that you've completed a structured neuroscreening exam, including cranial nerves, visual fields, limb and truncal ataxia, and a walk test. These are the components that are most often missed and are such powerful risk stratification tools to easily look for. The nature of the symptoms, whether they're disabling versus non-disabling, along with the time frame from symptom onset, will then guide the urgency of your investigations and your management. If you are in the habit of completing a systematic basic screening neuroexam for all of your neurosymptom patients, you're going to catch these cases, and it's going to make a really big difference for the patients under your care.
I love that despite the CT, CTA, MRI, perfusions, and endarterectomies, it still all comes down to the physical exam is the most important thing, which can't be said about too many other emergency department diagnoses that we make. All right. So what are the most important things to remember from this discussion on non-disabling strokes? I'll go back to the beginning of our previous podcasts and say that there has been this paradigm shift. It's no longer about major versus minor stroke. It's about disabling versus non-disabling stroke, which needs a discussion with the patient and their family. High-risk TIA requires the same urgency and approach as a non-disabling stroke. They're a continuum of the same disease process and carry pretty much the same risk, and they're managed pretty much exactly the same way. Stroke mimics are common, and we need to think about them and sometimes screen for them in all patients, especially those with non-disabling stroke symptoms. Just like TIAs, all non-disabling stroke patients, except those who are booked for an endarterectomy and those whose etiology is atrial fibrillation, will require dual antiplatelet load in the ED and a prescription. Those booked for endarterectomy get single antiplatelet therapy, and those with atrial fibrillation or a dissection as the etiology, either of those probably warrants a phone call with your neurologist to look at the many options in those cases. And then finally, remember that a good chunk, 10% of strokes happen in patients under the age of 40. They could be atherosclerotic, they could be dissections, they could be sickle cell, they could be atrial fibrillation, they could be a PFO. There is a long list of etiologies of stroke that we need to think about in the emergency department because it will change our management. Thank you so much, Walter and Katie, for your insights into the wonderful world of non-disabling strokes and disabling strokes from our last podcast, part 1. Before we go, if you are interested in more neuro-EM CME opportunities, Katie offers the Synapse course. She's built a condensed module for how to perform an efficient structured ED neuro screening exam that is fantastic. So if you need to find out more about the Synapse course, Katie, where should we direct people to?
Thanks, Anton. Feel free to check out our newly launched website. It is synapsecourse.com.
Great. Thanks so much, guys. That was a lot of fun.
That was great. I appreciate it.
Thanks. And for the listeners out there, if anyone is curious, Miss Bieber actually ended up having a PFO as the cause of her minor stroke.
These things actually happen. Amazing.